That being said, I think we'll go ahead and get started. So, Drolly, thank you for joining us. And would you like to give everyone a short introduction?
Yeah, pleasure to be here. Yeah, I'm Drolly. I'm a clinical psychologist. I did a undergrad in psychology, and then did a graduate diploma, and then did a combined master's PhD in clinical psych. And I went straight out of that pretty much to working in the field. So while I was doing my own postgrad, I taught a lot of psychology undergrad units. And then when I finished the course, I went to work at a hospital, and I'm still working in that hospital at the moment, a few years later. Um, so basically, my my life at the moment is split into about 3 days a week doing clinical work and other duties as a clinical psychologist in the hospital, and the other couple of days I'm doing research work for that same hospital. And that's pretty much what my life looks like at the moment. I've also got a couple of kids and a puppy sitting with me right now. I'm the only one in the house responsible for this puppy right now, so if she goes absolutely ballistic, it may disrupt what we're doing, but I'll let you know if that happens. Otherwise, I'm just excited to be here and talk about psychology and whatever you guys want to ask and chat about.
Definitely. Well, thanks for joining us. And I think we do have quite a few questions to ask you about psychology tonight. So we will jump right into it so we don't waste any time. Our first question is, what has been the biggest challenge for you working as a clinical psychologist so far?
I mean, I really, firstly, I'll say, like, I really got excited reading these questions, and I was thinking about that just before we started, like, why it's so exciting to get asked a question like that. Like, what's your biggest challenge? Why would someone like be excited about that? And I realized it's probably pretty similar to the sort of thing that I really value that I'm giving to clients, like an opportunity to sort of reflect and um, to sort of like figure out the things that they're good at, the things they might not be good at, and just understand themselves and the world a little bit more. So getting all these questions is really awesome. It makes me sort of think about similar sorts of things. And I'd say, like, in terms of what the biggest challenges are, that's something that I kind of constantly have to keep asking myself every now and then, so that I can address those weaknesses. So when I first started as a psychologist, I'd say the biggest challenge for me personally was like organization skills, because I was never really that organized. I could sort of get by doing a lot of my work fairly last minute, like sort of breeze through a little bit. When I started working in my psychology placements, I sort of quickly had to get really good at organizing my week, organizing my month, organizing my year, because a big part of working in clinical psych is being quite dependable, being quite reliable, and being where you say you're going to be, having done what you said you're going to do. And so I had to get a big, massive yearly calendar, fill it all out, and just get really, really organized. That was a big learning for me. It probably took me about a year to get really good at that. And then, yeah, I'd say like each year working as a psychologist has its own kind of new challenge that's opened itself up for me. The most recent one has been, I think, really sort of balancing what I know happens to people in the hospital setting, in terms of the suffering, in terms of like when someone tells me they've got a certain disease, or someone tells me something they've just been diagnosed with, or a treatment that they're just about to start. And inwardly, I then have all of these sorts of expectations about what I think their journey is going to look like, what their struggles are going to be, what their biggest challenges are going to be, what skills they're going to need to learn, all of these sorts of things. The challenge for me at the moment is not kind of imposing those expectations on every client that I meet now. So the more experience I get, I'm challenged to kind of like not meet someone new and just feel like I know everything that's going to happen with them, and so that sort of balance between sort of getting to know someone as they are and what they're actually looking for versus like developing my own ideas of what would be good for them and what they should probably be looking out for and probably be doing. I'd say that's where I'm at right now in the sort of my professional development. I'm trying to overcome that challenge.
Great. Well, thank you for sharing and very insightful as well. Our next question is, what is your experience with working with patients that have an eating disorder, and to what extent did your training cover eating disorders?
My training didn't cover eating disorders a whole lot. Really, in postgrad, all we got was sort of like a framework for how to go about doing one approach to therapy, which was cognitive behavioral therapy. And then we got like a sort of teachings on types of disorders and a rough sketch of what an intervention using CBT might look like for those different disorders. CBT, so eating disorders is one of those that I was sort of told about and given a bit of a loose framework about how CBT might be used to help. But beyond that, I haven't done any more training for eating disorders, and I haven't really come across someone with a full-blown eating disorder that I've worked with. Having said that, I've worked with a lot of body image issues, which have kind of led people towards disordered eating or unhealthy coping styles with their eating or their exercise. And that's just been something that I've had to sort of have open dialogue with people about, about how they feel about their body, to what extent their disordered eating is a problem, is causing problems for their life, to what extent it's not, and coming up with a bit of a plan about how to keep it under control. So yeah, I would say non-acute disordered eating is something that I've got a lot of experience with, but probably not full-blown eating disorders like anorexia or bulimia. And if I had someone in that category, I would refer them on to someone who is a specialist in that area.
All right. Our next question is, what did you teach about Thomas Szasz in undergraduate, and how did students receive it? And if you are familiar with this figure, maybe you could give the audience a rundown of his specific ideas as well, so they have some background in it.
Yeah. I really like Saz's work. I talk about him a bit in the server. I think so. Thomas Szasz was a really famous psychiatrist who was very heavily involved in what's called like an anti-psychiatry movement, and he famously wrote this book called the Myth of Mental Illness, and wrote a complimentary article which is a lot more digestible. It's got the same title. And what he's basically arguing is that the way that we think about mental illness is, in the modern day, often really misleading. We're calling things medical, biological illnesses without a whole lot of evidence to support that paradigm. And really, when you take a close look at what we mean by mental illness, Szasz argues that we're really just talking about people having problems in their life. And we should be able to help people sort out problems in their life without attaching this kind of medical concept that there's something ill or wrong with them. I think the really powerful arguments that Szasz makes is one that he kind of argues against this idea of a metaphysical mind. So he says, like, if we're talking about mental illness, really, what is the thing that is sick? If it's the brain or the body, then we're talking about brain damage. We're not talking about mental illness. And if we're talking about something wrong with a mind, well, firstly, do we even believe in a mind, like a non-physical mind? And if we did, how could it be ill? like how could it have an illness in the same way that we understand illness to mean for like a physical body part? So he questions a lot of these things, and um, ultimately, what I think his most valuable point is that underlying psychiatry and also psychology, which is implicated in all of this, underlying all of the concepts behind mental illness are a whole lot of ethical assumptions that people are making about how life should be lived, what a good life looks like, what problematic behavior looks like, what good behavior looks like, and essentially these are just ethical statements that are, preferences. And psychiatry has a whole lot of these assumptions caked in underneath what we talk about when we talk about mental illness. So, look, whether you like the anti-psychiatry stuff or whether you have a problem with it and think that psychiatry is mostly a really good thing, I think those sorts of arguments are really important to be aware of because it sort of it stops you from, I think, even if you want to champion and defend psychiatry and psychology, I think it stops you from making some really fundamental errors in thinking. And it's a really challenging sort of statement, like mental illness is a myth. But when you dissect that and have a look at it, pretty hard to argue with the fact that we are just kind of imposing a whole lot of assumptions about what life should be. And I think that's important to keep in mind.
Definitely.
So when we taught that in undergrad, students had lots and lots of mixed responses to it. Some students really liked the fact that we were critiquing and questioning mental illness and psychiatry because it's quite appealing to critique and deconstruct things like that. And it's also a really good safety against the kind of authoritarianism that psychiatry presents. So if you can have some really solid arguments that kind of keep psychiatry in check, that's a really nice, powerful feeling, and I think that's valid. Some students really didn't like hearing about SARS and the myth of mental illness, and I think the biggest offense that people normally take to something like this is, hey, I or someone I know has a mental illness. It's really serious. It's really awful. This is not a myth. It's a real problem, and we really need help. How dare you sort of trivialize this? And I think I totally empathize with that sentiment, but I think it's sort of just based on a misreading of what SARS was really on about. And in fact, like the idea that if we changed the language around mental illness to be a bit more in line with ethics, with what SARS is talking about, preferences about how life should be lived, the fear that a whole lot of people would suddenly not have help anymore and not have any resources to support them, I think is a really interesting question in itself about like how we need in our society pathology to justify resources and funding and that sort of thing. It's a complex area, but that's why I love talking about it because it sort of opens up a lot of different doors.
Well, thank you for sharing your thoughts on that. And I think that kind of bridges the gap to our next question, which is, do you have any critiques of psychology?
I've got a really weird way of thinking about this sort of stuff. I think like I I definitely have critiques of the way things are right now, but I'm probably and maybe this is just because I'm like a cis white man, but I like am not so hung up on the fact that like psychology is not this perfect enterprise. We've been like constantly trying to figure out why people behave the way that they do and why sometimes that goes wrong for people and how we can help them. And I think generally we've been getting better and better and better and better at doing that. I think um, one of the biggest problems I think that psychology is facing at the moment is that we want to stop people from saying and claiming things that they have no evidence to claim. So we want to stop all the sort of spurious claims and really just exploitative or misleading ideas that some people might use. And so we use psychology as a science to make sure that we can sort of stop people from saying things that are just not true. But at the same time, a lot of psychology, I think, is really, really, really hard to test empirically. And a lot of what we're trying to aim at in a discipline like psychology are very subjective things, very individualistic, things that can't really be easily designed in a lab setting. And so I think like we have to be a little bit forgiving with the speculations that might come out of psychology and the fact that it might be valuable to sort of speculate about certain things or share certain perspectives that might not be really supported by empiricism. And so I think that's like the biggest critique I have for psychology at the moment is that I don't feel like we've got a clear way of resolving that tension between the need for psychology to be a science, but the fact that that kind of excludes a lot of things that we might intuitively want to be in the umbrella of psychology, like certain philosophical psychology issues, the kind of ethical issues that SARS wanted to talk about. And I don't think we quite have a clear way of like knowing when someone is just um, kind of speculating or offering quite good information out of psychology that's not really got empirical support versus when someone's just spinning absolute yarns and it's nonsense and there's clearly needs to be some kind of grounding in empiricism to bring that person back down to earth. That the fact that there's not an easy way of like telling apart those two different types of person, I think is the really big problem that psychology has as a discipline at the moment.
Great. Thanks for sharing your thoughts on that a little bit more. Our next question is, what are you doing right now professionally?
I talked a bit about this before. I work in a hospital, which means that I'm part of like a pretty small team of clinical psychologists. We can get referrals from anyone in the hospital, and so usually it's the issues that I'm dealing with are patients who have just received a really awful diagnosis, or they're doing treatment that's really awful, or um, they are trying to adjust to all the changes that have happened in their life because of their illness. That's that sort of thing. So normally I like meet people for 3 to 6 sessions. Sometimes it's a lot more sessions than that. Sometimes they're just one-off sessions. Um, and so most of my work is that sort of clinical stuff. But there are also sort of research projects that come out of a hospital, like there are funding opportunities either in the community or from the hospital itself, asking whether people have ideas for research projects. And usually we all try, like every department in a hospital tries to bid for funding. And so we might like pick something that we think is really needed and see if we can do like a evaluation of that program. And so some of my work involves like collecting data and doing some data analysis as well. What else? Um, yeah, and I've just been trying to start a new project, which is like helping the doctors a bit more because I think like over the last couple of years with COVID and stuff, the burnout rates and the exhaustion and the mental health problems of doctors, especially junior doctors, has just been really awful. So we've been trying to figure out like ways to extend psych practice to them as well, so they can have some like debriefing and and support groups and that sort of thing. It's really tricky to do that. There's just like a lot of red tape to jump through. So at the moment, I'm trying to look into how I can like deliver that service in the hospital as well without shooting myself in the foot, getting into trouble legally.
Well, that's a very thoughtful project that you're starting to look into, so thank you for that. Our next question is, if or how does existential thought permeate your work? Is it especially useful in palliative care, or has it always figured into your practice?
Um, so I'm a junior, like I'm early on in my career, but I always knew that I wanted to focus on existential stuff, and that's probably why I gravitated towards this hospital for placement and why I was a good fit there and why they wanted me to come back and work there and that sort of thing. So existential thought permeates a lot of what I do, but I think that's, you know, um, it's partly because I've designed it that way to be in a place where that is really relevant. Um, when people get really, really sick for the first time in life, it's a bit of an eye opener. A lot of the time, it's a real shock to the system. Um, people tend to, know in an abstract sense that they're mortal and they're going to get sick and they're going to die, and so is everybody else, and all of that stuff. But it usually takes like a pretty real event in life to sort of make that feel actual. Um, and they're usually the moments where someone will come to me and they're like really overwhelmed. They don't really know what to do with this new sudden realization that shit, like I am really vulnerable. I could get sick at any time. Uh, I'm going to die. I could die in a year. Could die in 5 years. Um, so yeah, I think that stuff is completely permeated in my work, and I would say that a huge part of my role is being somebody for whom those topics aren't taboo, um, so that people can bring them up with me. And my goal isn't to covertly try to change topics, shut down that topic, um, convince them that it's all going to be okay, tell them my belief about or my like attitude in the face of death and illness and all of that stuff, but really just like kind of spend time with them in that topic, so that they can start to get more comfortable with it. So part of that's just exposure, like exposure to the ideas of death and illness and that sort of thing. And over time, they just get more and more comfortable with that stuff. And also, like in it through the dialogue and through the questions that I ask and that sort of thing, they come to like generate their own values in that area. Like, well, what's my response going to be to these problems? And everybody, like, ideally, will arrive at their own sort of response. And that I would say is just a um, really common um, it's a really common pathway of treatment that I'm having with people throughout my week. In palliative care, I thought that I would be dealing with that times 1,000. I thought I'd be dealing with those sort of existential questions a lot more, and I do a fair bit, but there is a really different feel when people are in palliative care because, to some extent, most people there have kind of, it's not taboo anymore because they've had to deal with the fact that they're dying, one way or another, and they're really interesting conversations to have with people because a lot of the time all of the normal taboos have broken down anyway. um, I find with palliative care, a lot of the existential problems that I'm working with is less about death and meaning and purpose and stuff, and more about suffering. It's more about like why do I have to go through this pain, that sort of thing. Um, so the kinds of existential questions that people are tormented by, they do change depending on the context they're in. And I find palliative care is a little bit more grounded, actually. It's a little bit more about like suffering, a little bit more about just like alleviating suffering and that sort of thing, rather than what's the meaning of life, what's the purpose of my life, and that sort of thing. That does come up, but a bit less so, actually. And In terms of how it figures into practice, Yalom talks about, needing to actually notice when people invite you to talk about that stuff, and I've sort of been paying attention to that over the last few years. You do notice that people will open doors in conversations towards death or suffering or that sort of thing all the time, and it's once you're looking for it, you realize, oh, people like are really just mentioning this stuff quite often. It's just that normally we would gloss over it and we'd go to the next thing. Um, or they say it in like a kind of jokey way, like, oh, but oh well, there's nothing, that's just life. But if you sort of stay there a little bit longer, then you get to see whether someone it's actually a problem for them or not. And for some people, it's totally appropriate to gloss over it. For others, you really need to integrate it into the practice. And you can't really do that unless you're willing to sort of notice those moments and then just like stay there a little bit longer with somebody. It's hard, which is harder to do than it sounds, because you're kind of, it's kind of like someone notices a rock in their shoe, and then you're just like asking them to just, oh, hold on, how's that rock feel? And you feel quite annoying in a conversation doing that sort of thing. But a lot of value can come out of it.
Great, thank you for sharing. Our next question is, how would you recommend getting started on reading Jung? Do you have any words of advice or of warning? And perhaps again, you can give a brief rundown on this figure's thoughts and ideas for the audience that might not have as big of a background on this.
Yeah, he's Jung's a weird guy. He it's pretty hard to recommend like where to start with Jung, because he did so many different things and they're all quite different to each other. Like a lot of his books and a lot of his writings are really different in what he was trying to achieve. Like some of his goals are clearly scientific, some of his goals are clearly philosophical, some of his goals are psychotherapeutic. Sometimes he's talking to fellow psychotherapists, sometimes he's talking to everybody. So like his works are just really varied. And so I mean, that's a big piece of warning in itself. Like, a lot of the time, I feel that people are reading Jung, um, and they're kind of analyzing what he's saying about one thing through a different lens. Um, for example, we would give a lot of leeway to someone like Nietzsche because he calls himself a philosopher, and we let him do philosophical projects, and we don't expect him to support every claim that he's making, or even we don't expect all of his claims to be empirically supportable. Some of them are metaphysical. We give him a lot of leeway, but then with someone like Jung, because he's done this work in scientific practice, and he did a lot of cool science behind personality and other things like that. He'll then write a book that's equally metaphysical, philosophical musings. But if you analyze that through the lens of scientific psychology, it looks like garbage, right? So I think with Jung, the challenge is to kind of like approach each piece of work with an open mind about like what he's actually trying to do with that, and what approach he's making. Is it a scientific empirical one? Is it a philosophical one? Is he just musing? Is he speculating or whatever? And I think he's for the most part fairly good at like making that clear, but yeah, it's a bit tricky. Look, the best place to start, I think, is Memories, Dreams, Reflections, because it's just a really nice, easy read about his whole life. You get a sense of like, it's written partly by him, partly by one of his disciples, I suppose you could call them. And I find it's a nice way of like getting a little taste of like his personality and some of his theories in the context of what his life was actually like and what he did throughout his life. And so I would like to start there, and then you can kind of like delve into the ideas in a lot more academic rigor if you're interested in those. I got this book called the Portable Jung, and that's got like a collection of all his really important essays and stuff, and that's a good one. The Portable Jung is another really good one.
Thanks for sharing your thoughts on that. And then our next question is, how do you, as a professional, stand in relation to the rest of psychology? Do you consider yourself an uncommon practitioner or thinker in some way?
Um, I was thinking about this question, and it's a really hard one to answer because, like, where does the rest of psychology stand? I mean, I've got no idea. There's there's like you can sort of see in the server anytime a kind of controversial topic is brought up, or anytime a topic is brought up in psychology, there's usually a fair few competing perspectives. So in terms of like the rest of psychology, I don't feel like there is this unified psychology that I'm either within or without. Um, there's just lots and lots of people doing lots and lots of different things, and I agree with some of them, and I don't agree with others. I'm I am probably like if I had to just describe my biggest interests in the field of psychology, it would probably be humanistic person-centered psychotherapy first of all, um, which probably pits me a little bit as an antagonist to um, people who would see me as quite muddle-headed. And I imagine a lot of behaviorists would see my approach and my way of looking at it as a bit muddle-headed. Um, I think people who are extremely defended and guarded about the the strictly biological lens of psychology, I'd probably be a little bit. They'd probably be a little bit antagonistic towards me there too, because I can be a bit dismissive of the biological stuff sometimes. Um, but in terms of how I like just do my job, I think I think the uniqueness of what I do is probably quite subtle. It's probably just like how I use my own personality in sessions and stuff like that. That's probably where my uniqueness comes from. I don't think like I'm doing anything in psychology that's, you know, really unique or groundbreaking. I'm like trained in cognitive behavioral therapy, and that's obviously a really mainstream modality that I think is really helpful, and I really like it. I use that whenever it's useful. Um, and then I've been like trying to follow the footsteps of all these existential psychologists as well. So I don't think that's particularly uncommon. I think the other thing that question reminds me of is just that I suppose like how different the areas of psychology are. So like this comes up a bit later in other questions, but like what's common for me working in a hospital is going to be really uncommon for someone else doing work in a clinic that specializes in eating disorders, for example, or a clinic that specializes in children and families, or a school, or whatever. So the issues that I am working on are often a lot more um, specialized about health and pain and death and dying and that sort of stuff. Um, and so I'm probably, compared to a lot of other psychologists, really odd and uncommon. But for if I met other people who were doing similar work to me in hospitals, they'd probably the things I would talk about, they'd probably go, yeah, yeah, that's really familiar to me as well. So I think we're all siloed off in our little areas of expertise.
Thank you for sharing your thoughts on that question. I think you did a great job answering it.
Thanks. Oh, I think the other thing that makes me uncommon is I'm quite silly. I think I think I'm like quite silly and I laugh a lot and I laugh at myself a lot, and that sort of thing. So I haven't found that many other psychologists who are as silly as me yet. There's a few, but I really value silliness. I think it's good.
There you go. That's a great thing to bring to your practice. And
Yeah.
then our next question is slightly related. How did you come to work in end of life care, and how can we do the same?
So I think for me it was just about trying to find placements in my training that were in real areas I might want to work in. I was kind of pushed to do that anyway. Like in the postgrad, you kind of really asked to reflect on where you would like to do placements, and you kind of autonomously have to organize them for yourself for the most part. So that was the first thing, is I knew I wanted to sort of deal with existential stuff, and I thought hospital where people are sick and dying is probably a good way of getting involved. So I did a placement in a hospital, and as I said, I think I was just a good fit there, and so I stayed. And so I think like really about like if you want to get to a certain place and work there, it's just about sort of um, looking at what opportunities are around you, and trying to slowly take steps towards those places. Um, Palliative care is a sort of a different beast again, because some hospitals have palliative care wards and others don't. There's like community palliative care clinics as well. There's aged care facilities. So there's lots of different types of places in the community that deal with people at end of life. And I think it would just be about kind of like trying to get some experience in those places at whatever stage of your career you're up to.
Great. And again, building off that question, have you had any personal experiences prior to becoming a psychologist that has helped your posterior practice in any way?
Well, I mean, like I am a big believer in our using our personalities as tools in therapy. And so in that sense, like most of the experiences I've had in life are have like shaped my practice. And we sort of I think we use our I use a lot of self-disclosure and a lot of sort of storytelling and things like that to sort of relate to different people. And so I think just having a lot of different life experiences is really helpful. Being able to sort of have lots of different reference points in society, like knowing about lots of different subcultures, and um, you know, having gone to in Australia, I've gone to bush stuffs, and I've had a clubbing phase, and had a very studious scholarly phase, and had times where I got really into going to the gym, and you know, times where I've been really, really into video games, and so all of these different experiences I think can be useful to sort of like finding shared reference points with clients, and forming connections and stuff. Um, I did a fair bit of therapy when I was a late teen, early in my early 20s, and that's hugely shaped how I do therapy as well. So I did individual therapy for a while, and I did group therapy for a while, which was sort of more like they were sort of like personal development sessions that I did for years with a particular group. Um, I think that helped me a lot because um, I wouldn't say that I had any like acute problems, but I was really, I think, really understimulated basically, and so when I did a lot of self development in a therapy setting, it just gave me a lot of confidence, gave me a lot of like comfort with um, the kinds of sensitive topics that get brought up in psychology, the kinds of questions and comments that people make, the kind of language that you use in those settings, um, being able to be really odd, being able to kind of be that person to tell someone there's a rock in their shoe and ask them what it feels like. All that kind of stuff where you're just kind of having quite unusual conversations. I think that all really helped me a lot, just to be more outgoing and confident in my sessions. I felt like I could hit my first placement running because I had already been in therapy rooms and stuff a fair bit, and so I felt quite comfortable there.
Very insightful. Thank you for sharing those personal experiences. And I really like the rock and the shoe metaphor that you've been using so far.
Thanks.
Our next question is, what is it like working in a hospital versus an outpatient setting?
So I work in a hospital, but most of the work I do is considered outpatient, in that people I'm not seeing people in wards; they're coming to the hospital, and um, but I do a fair bit of inpatient work as well with people who are staying in wards. It is really, really different. It's a really different set of skills interpersonally, um, and I think for let's see. I think the the biggest challenge with inpatient versus outpatient is that often an outpatient has a motivation to organize the session. They are coming to see me. They've got an idea that something is wrong. They can start verbalizing what's wrong. We can start a conversation in that context. And so there's quite a lot to run with at the beginning. And that gives a really nice foundation for starting a relationship with somebody. Whereas when someone's an inpatient, essentially, most of the time, it's someone around them has asked you to go and see them, like a doctor or a nurse or a family member. And so you're kind of just like walking into somebody's temporary home with all of the stigma that surrounds mental illness, psychology, psychiatry, all of that stuff, and just kind of introducing yourself and trying to establish a trusting relationship. Um, that's really challenging. It's a very different skill set interpersonally, um, and you know, there's pros and cons. Some days I hate the idea of walking into wardrooms and just feeling like I'm on the back foot and I need to like really sell myself. Um, Other times I am really keen for that and I really like I really feel like feeling like I'm on the edge of my seat and I'm like really needing to just um, walk into a room and just spontaneously kind of see how someone's doing and react, and respond. Um, so yeah, I think that the work is very different, but it's just pros and cons. So they're rewarding and not rewarding in different ways. Oh, I think the other thing is that inpatient work is just really chaotic. So, like, you have to deal with a fair bit of organizational chaos with inpatient work. Like, you can't have a nice booking from say 1 o'clock to 2 o'clock and know that oh, this is the time I've set aside for them, because you can go up and someone's taken them away to do a scan, or they're surrounded by nurses at that time, or there's just always stuff going on in hospital wardrooms that disrupt what you're trying to achieve therapeutically. And so you've got to be able to just like work with a lot more chaos, and that's quite challenging.
Definitely. And again, what has been your experience like in working with psychiatrists, and how do you incorporate them into how you care for your clients? So, again, building off that previous question.
Yeah, I mean, I work really closely with psychiatrists in that we have a psychology team and we have a psychiatry team, but they're all subsumed under an umbrella of psychosocial care. And so we meet every day. We have a handover meeting in the mornings where both teams discuss any of the clients that are being cared for by both teams, or any clients where there's a question about what team would best be placed to care for them. So we are always in like open dialogue with the psychiatrists in the hospital as well. Um, Typically, the border cases, so typically psychology is there to help people with a little bit more longer term, a little bit less urgent needs. And psychiatry is there to help people who need a much more urgent intervention, or patients who are not able to engage psychotherapeutically, so they've got some like acuteness of what's going on where they just would not be able to have sessions to get benefit from them. Either they can't talk because of physical impairment, they aren't interested in talking because of interpersonal stuff going on, they hate psychologists. You can imagine all these different barriers. um And then also obviously just acuteness of situation as well. So if someone's got like a really acute psychiatric issue, like psychosis or borderline personality or stuff like that, psychiatry will be involved as well. And often with really extreme cases, both teams will be involved. So um, psychiatry might start work with somebody, make sure that they are stable enough that they can be interacting with the hospital in a healthy way, going to the appointments they need to go to, not so distressed that they're a danger to themselves or others. There's like some stability there, and then they'll refer to us and say, look, we've got them to a bit more of a stable place, but can you please see this person for like a few sessions and help them like maintain these benefits. And that sort of thing. Or another example might be, look, this person had really severe insomnia. They just weren't sleeping at all. They're worried every night about everything. I've given them some sleeping medication. It's going to help in the short term. We don't want them to stay on this long term. So can you start working with them as well about sleep issues and managing their anxiety and that sort of thing? Because we want to wean them off this sleep medication in about 6 months. And so, there are lots of different examples where we might be working together to help the same person or referring back and forth across the teams if we think that they're going to get better care with the other discipline.
Great, thank you for that perspective. Our next question is a little bit outside of that box. What is your advice for undergraduate students who lack research experience and want to apply to clinical psychology, PhD, or PsyD programs? And our
My
master's,
advice.
oh,
Sorry. Did you want to finish up?
yeah, sorry, there's a second question. Are
Sorry.
master's programs a good way to gain experience before applying?
So I think this is one of those questions that's really uh, dependent on geography. Like where you are in the world is going to really depend on what pathway you need to go through to become qualified as a psychologist. Um, in Australia, where I am, the clinical work and the research work are really distinct. Um, so if you want to be a psychologist, you have to do a master's. If you want to be a researcher in academia, you want to do a PhD. And so they kind of branch off. Whereas my understanding is like in other parts of the world, if you want to be a clinical psychologist, you actually have to do a master's and then do a PhD. They're not like branched off like they are for us. They're like a linear sort of program. Um, but my advice for this kind of question anyway would be meet with people. So when I wanted to get into masters, I met with the head of psychology at the uni. I basically just wanted to meet with a few people who I saw as being really high up and really reliable and really like honest. And I just asked them whether they had like 10 minutes to meet with me. And I basically asked them the same question that you just asked me about, like, how do I help my chances down the track? Because different courses and different unis have kind of like different criteria and things that they're looking for. So the most important thing you could do for yourself is like speak to someone who's actually on those panels deciding like what students they let in. Um, I spoke to someone who was on the panel and he basically said like the three criteria you always want to be balancing in your head is like like length of experience, like how many years of experience someone has, responsibility. So like how responsible were you in those roles? Did you like have to be responsible for any other team members? Did you have to like be responsible for any participants? Did you have to be responsible for any data? And then acuteness. So like the other criteria is like how serious is the issue that you're dealing with? Like how intense are the problems that you're working with? Like if is it a research program about like serious mental health issues, that kind of thing. So like those three dimensions, like length of experience, responsibility in experience, and the acuteness of experience. That's like a kind of good rule of thumb for what you're trying to get under your belt. But yeah, I would just book a meeting with someone in charge of the program and ask them what they're looking for.
Great advice. Thank you for sharing it. I'm sure it's going to come in handy for plenty of our audience.
Yeah.
Our next question, swinging back to your professional career. In your clinical experience, what are some disorders that you have found particularly difficult to treat?
Um, I think what stands out for me in my early learning, like my early career as a psychologist, which I'm still in, it have been the patients who sorry, and I say patients as a bit of a habit because I work in a hospital, like they actually are patients, and that's what everyone refers to them as. So forgive me. I know it's a bit of an antiquated thing to say, but when I say that word, I'm not meaning they're like my patients per se. I'm meaning like they are patients at the hospital. Anyway, the cases that I found particularly difficult were, people who did have um, flavors of personality disorder, people who like really clearly needed help and were interacting with the hospital in a way that was clearly problematic, but who had experienced enough trauma in life or enough untrustworthy people or enough bad luck in their life that they really didn't want to take help from anybody. And so, these are people who are like constantly seeking support, but then when support is offered to them, it's never good enough. It is always missing the mark. The people are always making mistakes from their point of view. People don't care about them. People are always abandoning them. Um, and so you can imagine in a hospital setting, this is so difficult because every nurse that interacts with them becomes much more distressed. They like often feeling really guilty or inadequate or worried about, their own professional reputation. The doctors get burned out a lot more quickly. Like often patients like this who are really used to being abandoned or betrayed will sort of accuse doctors of doing that to them. Like, and it can be pretty serious accusations, like they're withholding life-saving treatment from me because they don't like me, that kind of thing. Um, yeah, so those sorts of things are really difficult, and I think like therapeutically they're really difficult as well because alongside all of the fallout that you're trying to clean up with all the nurses and the doctors and family members and all the chaos around presentations like that, the person themselves, often the way that you are overcoming those problems is with rupture and repair within the therapeutic relationship. So essentially what that means is that you're kind of offering yourself as a reliable, supportive person with really clear boundaries. And then what will inevitably happen with someone with those sorts of personality issues is that they will perceive me as betraying them, hurting them, not doing good enough by them, and start to get into a fight or a conflict with me about that. And then we need to resolve it. And then in resolving it, we're both learning how to resolve those kinds of conflicts, and they're learning like how to raise them in a way that makes it possible to resolve it rather than just screaming at someone or just cutting someone off or whatever. But yeah, that means I've often got to spend time with people who hate me like a fair bit, and they don't want me to be there, but they don't want me to go either. And so I'm sort of sitting with them in this hospital room, and if I stay, they're just going to give me greasies and have their arms crossed and call, say, oh, and here's this other mistake you did, and here's this other reason why you don't like me and you're bad and all this stuff. But if I go, then they'll say, oh, you see, you're just one more person who betrays me and abandons me. Right? So you end up caught in these really tricky dynamics. I'd say they're the hardest webs to try to disentangle yourself out of in a neat way. And and the other thing that's really tricky there is often when you do achieve a really good connection with someone like that, then you have to deal with the pain of trying to discharge them from the hospital, right? And can you do that in a way um, that doesn't repeat this sense of abandonment? It's a very tricky thing.
That does sound very difficult to deal with. Our next question is, to what extent did your education cover psychoactive medications? How has your knowledge on these medications helped you in your clinical practice?
Um, so, psychoactive is a very broad term. I which would include like psychopharmacology, but I assume this person would have said that if that's what they. we um we had the training was for psychopharmacology was one unit. So and it really a lot of it went over my head because I hadn't done the neurological anatomy stuff as a foundation. So I'm still quite at a loss with a lot of the science behind psychopharmacology stuff. In terms of like psychedelics and other drugs, we touch on the disordered ways of using those substances when we learn about all of the different adult psychopathologies that people can experience. Like addiction disorders and um, caffeine abuse disorder and all these other things, substance-induced psychosis and those sorts of things. So you sort of touch on where those things can go wrong. I think where a lot of gaps were is learning about drug use in a sort of non-acute setting, and the kinds of things that the kinds of effects that they can have on people. Personally, like I said before, I went through a lot of different walks of life before becoming a psychologist. So I'd sort of been involved in social groups where people were using psychoactive drugs and other things like that. Um, and I feel like all of those experiences are really helpful because people often get people people have just like really varied experiences with psychopharmacology drugs, psychedelic drugs, everyday drugs like coffee and alcohol and that sort of thing. Um, and so I think like even though my education on those topics were fairly minimal, just being able to break down the kinds of experiences that people have with different drug taking is just a really good. It's just really good to like kind of have a set of questions that you can ask someone to get a sense of like whether drug taking is like a problem or whether it's just like a recreational thing or whether it's a medical thing or whether someone's using it drugs to like uh, cope with a particular problem or achieve a particular goal, sort of thing. Um, yeah, I don't know if that answers the question. The training's very minimal for me in terms of like knowing all about different drugs. That's one area that I'd have to do more professional development in if I wanted to talk with more authority.
Thank you for doing your best to tackle that question, and perhaps the
Mm.
person that asked that question can put something in the chat if they wanted to follow up with any specifics they were wondering if you could cover. But in the meantime, we'll move on to our next question, which is, what research experience do you have? Do you find yourself in doing research from the cases you have seen in clinical settings?
Yeah, so like I started research before doing clinical work. I did my fourth year thesis, and then I did a PhD, which I think I was one of the last people to do it the old-fashioned way, where you just like write a massive document instead of submitting heaps of articles. And I'm still trying to like parcel out little articles out of that big document to publish. But my research was on it was on so it was on scale development, and it was on basically trying to measure different belief systems that people have about the world, um, uh, like spiritual belief systems, naturalistic belief systems, agnostic belief systems, that sort of thing, um, and seeing whether they could be predicted by cognitive styles. So, like, do people end up believing different things about reality based on like cognitive tendencies, like smaller cognitive tendencies? And then also, are there different well-being outcomes to having different belief systems? So that was really fun. I essentially like had to wrap my own head around what belief systems actually are in personality and in cognition and in the context of psychotherapy. You know, some of the ethics behind trying to change people's belief systems or challenge them. Um, and I did all of that before starting clinical work. And then after starting clinical work, I'm still involved in research in the hospital. And yeah, that is much more generated based on sort of what we see in what we see as a need in the hospital. And so it's not so much like seeing individual cases and responding to those, but more so like seeing bigger trends in the hospital. So, for example, like just that men are really less likely to engage in psychotherapy and supports in general, really. Like men typically seek support much less than women. And so, like, there's a research question there that we're trying to get underway about, like, what are men's experience of people reaching out to offer support? What are the things that tend to trigger them to seek support? What are the things that put them off? What are the things that make them more likely to engage? That sort of thing. So yeah, I wouldn't say they come out of individual cases, but definitely research questions come out of like broader trends that we see in the hospital for sure.
Great. Thank you for sharing your background on that.
Yeah.
And our next question is, what is your advice and or suggestions for a budding clinical psychologist?
A lot of so the training is really great, but in a lot of ways it teaches you a lot of skills that are really wonderful to have, like interpersonally, ways of thinking about problems, ways of writing and resolving um, pretty complex presentations in your writing. There's a lot of cool skills that you learn, but in my experience, the clinical psychology training is really harrowing, and it really makes a lot of people feel incredibly doubtful about their own skills. And it's like a bit of a meme that everybody has imposter syndrome, but I actually feel like there's something unique about the way that clinical psychology training happens that really seems to intensify this feeling of inadequacy. We're kind of taught to doubt nearly everything that we say. We're taught to like be very perfectionistic. We're taught to be, like uh, any solution that we could come up with. We're taught to like think of, oh yeah, but how could that be a problem too? So there's just this like constant like so the benefit of all of this is that you live a reflective life and a reflective practice where you are kind of looking back on what you're doing and evaluating it as you go. But the shadow side of that is like treating yourself like shit and being really critical of yourself, not letting yourself say anything with confidence, it's second guessing every piece of advice or everything that you deliver to anybody else. So I think there's this like real fear that is given to people when they do clinical psychology training. And the advice that I would give is just to be really aware of that and be aware of like the dark side of what is being kind of uh, trained in you and be a bit nicer to yourself. Like be a bit this is like part of the reason why I wanted to join this server, do AMAs, chat with people like this, is just to get a bit of confidence back. And so yeah, I think like just go a bit easier on yourself. Be a bit be a bit patient. You're allowed to say things that are, um, you know, 60% right and 40% wrong. It's okay.
Definitely some very good advice there that you just listed off. And again, building upon that question, do you have any book recommendations for basics of counseling for beginners?
Few of us in the server talk about the Corey book. I really like the Corey book. I forget the title of it exactly. I think it's like Theory and let me look it up. Theory and Practice in Counseling or something like that. Theory and Practice of Counseling and Psychotherapy. Very expensive book, which is annoying. It's written by Corey, but it's really good. The reason I really like it is because he basically has a chapter on like each of the major schools of psychotherapy, and he takes you through each of them in turn, and so you get a sense of how like you can approach therapy from a lot of different angles, and each of those different angles has its own kind of like philosophical underpinning, got its own like model for understanding how problems come about in people's lives, how they can be resolved, what to do in sessions, and all of that stuff. So I really like it because you get he delivers quite a lot of depth and quite a lot of breadth as well. So it's good to start with because you get this like really nice kind of sense of there's like lots of different ways of doing this sort of work. And he's quite like a light-hearted, straightforward writer as well, which I really appreciate. That's probably the best one I'd recommend. Um, the other one that I always advertise in the server is Interpersonal Process in Therapy, which is it sounds like it's a textbook for a particular approach, interpersonal process therapy, which is its own sort of style and approach to therapy. But really, the kinds of skills, interpersonal skills that it's talking about, I think every therapist should be pretty good at them. So I'd really recommend that book as well.
Great, thanks for sharing. And perhaps after this AMA, if you wouldn't mind putting a link to those books in the
Yeah,
presentation
will
channel.
do.
Perfect. Thank you. And again, building off book recommendations, do you have any recommendations related to anecdotes in clinical or psychology in general?
Um, so I think like one thing is that again you could be quite specific about what type of psychology work you want to hear anecdotes from. So you could get books that are giving you anecdotes from a patient's perspective. You could get books that are giving you anecdotes from like the clinician's perspective. You could get books from clinicians doing work with like really acute psychosis. You could have books about working in general practice and that sort of thing. The one I'm most familiar with Yalom because I've read most of his nonfiction books, and he has a lot of anecdotes. I think part of the reason he's so popular is that his books just have a lot of very down to earth, very grounded stories about his own experience being a therapist. I think the most popular one he's written in that area is The Gift of Therapy. He tells lots of stories, and he's really written that book to new psychologists or new counselors to share his wisdom in the form of little stories and aphorisms and stuff. So that's a good one. I'm trying to think of also and interpersonal process in therapy. That one I just mentioned has some really good like examples of like transcripts from cases and that sort of thing as well. So it's a really good book for illustrating the concepts it's talking about as well.
Perfect. And again, what are some good online free resources for students or learners of clinical psychology?
I've heard there's a cool psychology library server, somewhere here on Discord. Heard that there's maybe an invite link in the partnered server section of this Discord server. Actually, that's got some pretty cool resources. It's an amazing group of librarians I've bumped into once or twice uh, who curate that space. I think the other thing is to just uh, you might find that if you want to learn about how to do psychotherapy, you might do it on yourself a little bit. And there's some really cool books like self-help books and stuff like that. I've just found this series of books recently, which are called like Learning X from the Inside Out. So, like, they'll be learning CBT from the inside out, learning acceptance commitment therapy from the inside out. And they're like edited books that are basically like 12-week modules, and you can just go through it yourself. So, you can give yourself like a little unit of therapy. And they're sort of written to be accessible to practitioners or everyday people, and that sort of thing. So I think some of the best ways of learning how psychology can be helpful is to um, have an experience of it yourself and see what you can do. So yeah, there's some pretty cool online clinics as well. There's like this one called Mental Health Online. A few others I think that offer different things, like just checking out the kind of sort of stock standard things that they would be getting people to do, and then giving some of them a try and seeing what differences they make in your life. That's probably a really good way of getting some experience about these things.
Definitely. Thanks for sharing. And for those who are unfamiliar with the psychology library server that Drolly is referring to, you can find a link to that in our partners channel, which I just linked in the presentation done channel as well. Our next question is, do you make any time in your day to catch up on recent research?
No, I should do like I did. I should do this more often. I've noticed COVID actually really disrupted my keeping up to date with readings and stuff, because I used to do a lot of it on the train. I realized, and now that I'm getting public transport a lot less, I don't read as much because I just don't have these like half-hour train trips to bookend my day. So I have to figure that out somehow. Um, and the last thing I feel like doing when I get home from like doing psychology all day is like cracking open some psychology to read at night. I usually prefer to hang out and talk silly stuff. But I think the hospital I work at is really good for organizing professional development stuff, and so every every month at least we will have like a seminar organized for our team where we like get someone to present to us the most up to date research in a certain area. And so that's usually the way that I'm staying up to date with relevant areas. Having said all that, like when I am confronted with an area that I feel like I really need to know more about, I'll just do the reading on that then. So, for example, when I started working in palliative care and got that sort of position, I just bought, you know, did some looking around and found a book on palliative psychology and went through that. So I think like the research that I'm keeping on top of is a bit more probably a little bit more reactive than proactive these days. It's a bit more like what are the gaps that I really need to be filling in, and then going and seeking out that rather than just like having time allotments. Um, yeah. And my supervisor sort of each year we sort of come up with a bit of a plan about what my focus is going to be on professional development, and what sort of stuff I need to be reading up on, and what sort of stuff I might need to organize for myself in terms of seminars and training and workshops and that sort of thing.
Very nice. Our next question is, have you had any experience treating those with substance use disorders? In your opinion, what is the best way to treat substance use disorders?
So I don't actually have experience treating substance use disorders. I have experience working with people who have substance use disorders, but my goal is not to treat those disorders. My goal is to you know, do other work with these people in areas to do with their illnesses and adjustment and that sort of thing. Obviously, it's related in that people's stress and that sort of thing might worsen their substance use problems. So if the substance use is really bad and they really need support for that problem in particular, then I might refer on to someone who can work with that a lot more, um, with a lot more specialty. If someone already is working with an expert, or it's not quite acute enough to warrant that, I might just sort of be doing work with people about like functionally what are the um, you know, what are the outcomes of their anxiety, for example. They might say, "Oh, well, then I'll take this drug or that drug or whatever," and we might explore like alternatives that they might do to calm themselves down um, or get themselves fired up or that sort of thing. So again, normally the approach that I'm using when I'm talking with people about substance use is like a functional one. It's like what function is this drug giving you? Um, and is there a more functional way that you could be getting that same outcome? Um, and yeah, again, if someone was really acute in that area, I would refer them to a specialist. But sometimes we sort of like do broach in on that area a little bit. I think generally with addictions, um, my experience is that that's usually the big challenge is like finding other things to do. And so a lot of the time people kind of feel like when they're trying to stop a compulsive behavior or an addiction or something, like the important thing is being able to willfully stop doing that behavior. But I think a lot of the time the challenge is actually introducing new behaviors in life that serve similar functions, like help me have a really nice time, help me relax, help me feel social, help me like let my hair down, that kind of thing. And so I think with substance use and addictions, my impression is it's about finding those effective alternatives really early on, and it's sort of like there's a lot of behavioral activation happening. There's a lot of like lifestyle changes being recommended, so that someone is like not just quitting a drug or a problematic behavior and then just having nothing else to do in that time of their day.
All right, thanks for sharing. And this next question is directly related, so I'm not sure if you're going to have much of an
Mm.
answer for this one, but I'll ask it anyways. How common is marijuana use disorder, and is this something we should be worried about in adolescence?
I mean, it's that's kind of a teleological question. Like to call it a disorder um, says to me it's reached a point of being problematic enough that it's worth worrying about, right? Like it's almost like you answer your own question there from my perspective. I'm not quite sure how prevalent marijuana use disorder is specifically. Um, but if someone has it, then yeah, I'd say it's worth worrying about. You know, like I find that these thresholds are really tricky for people to work out, um, and particularly with adolescents, I think it's a struggle because um, this problem of um, psychiatry and psychology prescribing ethics is really pertinent here. We touched on it a little bit earlier, where it's like underlying the discussion about mental illness, there are certain prescriptions about saying what a good life should look like. And some people would sort of just put marijuana use in the category of like, it's just a problem if you're using it, right? It's not a good thing to do. Whereas other people just would not have that prescription, that ethical prescription for life. And so, I find it really interesting, this question of like at what point would we say like a teenager using marijuana is a problem in their life when it's not reaching that level of acuteness, you know? Um, and I see when I talk to the people in the hospital who work with youth, I think the feedback that I've gotten is that it's a really tricky. It's been made really tricky because of all the ethics that's been kind of like snuck into that issue, uh, where teens often don't want to bring it up at all because they're worried it will automatically be seen as a unethical behavior as opposed to just like a behavior that they might want to look at and manage and reduce if they need to. Sorry if that's a really fluffy roundabout answer. It's an interesting area.
No, I think you did a great job tackling that question. Thank you. Our next one is, in your opinion, what is the best way to approach treating OCD? What are some of the benefits and downsides of biological treatment?
Um, I'm not quite sure what biological if that means like pharmacology treatment. I assume like look, I don't know if there are any downsides that I would say apply to every person. I'd be really worried about saying that there are like universal downsides to having medication for OCD. I think the tricky thing with OCD is the tricky thing with psychoactive medications is that they're just really individual. They for some people they will have lots of downsides, and for other people there won't be those same downsides. So I think it's a lot of with medication. It's a lot of really intimate work with a GP or a psychiatrist to try to like get the right fit of medication. Um, in terms of treating OCD psychotherapeutically, I am trained in cognitive behavioral therapy as an approach, and so that's the modality that I would be approaching OCD with. And there are the thing that I really like about cognitive behavioral therapy is that you always have like the cognitions, the behaviors, and the emotions and the physiological sort of responses that people have. And you can kind of come up with interventions for any and all of those different domains depending on what people find to be the biggest problem for them. And so, for example, I worked with someone whose OCD was really all about reading. They were just obsessed with reading everything they could possibly read and checking social media about groups and stuff about their illness all the time. And so for them, the cognitive interventions where that we might challenge, say, their belief that something's definitely going wrong if they don't check those things, or that they're going to be misinformed, all their fears that might come up. Um, they really it just didn't work for them. But having some behavioral strategies like just structuring their day so that they did not have time to be checking these things or doing these things, that really made a big difference for them. And over time, when they were just forced to do different activities and not engage in these sort of checking behaviors, over time they just became a lot more comfortable with it. And we could go longer and longer periods of time without them checking. Now, other people really needed the cognitive side of it. They really need to be challenged on their sense of responsibility. So, firstly, like they've got these like beliefs that if something can go wrong, it will definitely go wrong, and if it goes wrong, it will be their fault for not having done this certain thing that they should have done. And so, for those people, like we might spend time challenging their sense of responsibility about things, or challenging their their catastrophizing, and that sort of thing. um, so yeah, I think like if that answers the question, I think like cognitive behavioral therapy is really really good for OCD, for managing OCD. But part of the reason it's so helpful in my opinion is that you can really tailor it to individuals. And then in terms of the medication stuff, I think the benefits and the downsides are just so individually dependent. I'd be worried about making any kind of like broad statements about that.
Perfect. Thanks for sharing your thoughts on that one. And our next question is going back to something you said earlier. Do you have any tips on giving oral presentations?
Well, this is a tricky question because I'm giving one right now, and so I don't want to like pretend like I'm doing a great job in case I'm not. But like, I actually can't tell whether I'm getting better or worse at giving presentations. I think I'm fairly good at them, but like, my my style is very cavalier, as you might tell. I'm like this when I give talks about most things. When I give presentations about grief and bereavement, I will maybe be a little bit less playful, but my attitude is ideally as spontaneous as this one, and a bit, I'm trying to just be myself. Um, I think everyone has their own things that make them feel more secure with presentations. Um, and for some people, it's being really prepared and having lots of notes. I find I prepare a fair bit and then abandon all my notes, and that's my process. But I just do a lot of self talk. I do a lot of self talk about like when I notice my physiological arousal getting really intense. I sort of talk to myself, say, I'm excited. This is really exciting. It's going to be cool. I'm going to hang out with all these people and have a fun time. And so I try to interpret what my body's doing in a positive way, as opposed to like interpreting it as a problem. Like, oh no, I'm getting panicked and anxious. So I try and like interpret what's going on in a positive way. Uh, I try to remind myself what the overall purpose is of the presentation. So, like, I don't get too distorted and wrapped up in all these false purposes. Like, it's very easy to catastrophize and feel like, oh, I've got to convince everybody that I'm really smart and I know everything, or I've got to convince everybody that there's that I deserve to be here, or whatever. You can get all these like false goals that come up if you know to look for those, and make them a bit more realistic. Like, oh, I was asked to do this, or I was like, there's an opportunity, and I've got X, Y, and Z that I can offer, and if people like it, they can take what they will. If they don't, oh well. It's not the end of the world if it doesn't go well, you know. So I find presentations are one of those things. They're nice little opportunities to like practice some of those CBT strategies on yourself. And then the other thing, of course, is just exposure, exposure, exposure. Just do them a lot and get a bit more comfortable being in that state of arousal, and being in that state of vulnerability, and being in that state of like, oh, my face is going a bit red. Oh well.
All right. Thanks for sharing your tips on that. And people in the chat are commenting that you are doing a great job so far, and I am inclined to agree with them.
Thanks.
So, our
I
next
remember when I first started practicing presentations with my colleagues in postgrad, and I eventually had to tell them to stop giving me tips, because they were giving me all these tips like, don't, oh, you keep picking up your mug and putting your mug down, and it's going to put people off, or you're standing too close to the thing, and that's going to, and I just said, yeah, this is not helping me at all. I actually, if someone judges me for picking my mug up and putting it down, I don't really care. They're probably, you know, not too interested in what I'm saying anyway. And so I try to focus on just being passionate and being like taking whatever energy that I've got about the topic, and just like delivering that as best I can. And people don't like it, they can just sort of do something else, I guess.
Well, I think your passion is definitely coming out with this AMA. Our next question is, have you had experience? Oh, I'm sorry, that was the wrong one. In your opinion, what was the hardest course you took while getting your PhD?
Um, so like, just gonna pass out the language here. So like a course, as I understand it, is like all of undergrad or all of fourth year or all of postgrad. Um, as opposed to like a unit, which is like a particular subject, like for 6 months, like a semester's subject. So I'm trying to pass out the language here. Um, I think the hardest part of my studies at uni was probably the end of undergrad, the very end of undergrad, where marks mattered more than they ever did, and more than they ever would again. And there was the most amount of juggling going on in terms of the amount of assignments and the amount of classes that I was doing. Um, and just the mounting pressure about like what next, what happens after this, and will all of these efforts be in vain, or will something good happen? So I think the end of undergrad was probably the most stressful time, and then after that, the other courses were much more stressful for me, but because of like just having life to juggle around them, not because of the course content itself. By the time I was doing my graduate diploma and postgrad, I was like trying to start a family at the same time. And so that was all really challenging. But I'd say if I bracket everything else and just look at the uni content, it's the end of undergrad that was the real challenge.
So I think for the person that asked that question, perhaps they were referring to course as like a specific class or subject, like
Hmm.
you mentioned earlier. So maybe if you could share a
Sure.
little bit about that as well.
Well, it's going to be boring for me because it's pretty cliche, but it was statistics. Like, I failed the first statistics unit, didn't put enough effort in, and then panicked, did it again, and got 50 out of 100 and just scraped through. And then by the time I got to my postgrad, I was getting HDs in stats. So something turned around at some point. Um, I don't quite know what the factor was. I think it was maybe just enough time and repetition that it clicked. Maybe it was like a certain tutor explained it in a good way and it just clicked then. But at the beginning, it felt like everybody else in the uni was speaking a language that I just didn't understand, and it was awful. And I really went through that same thing a lot of people go through, which was like doubting whether this is for me at all. I felt like I'd been cheated. Um, but yeah, I ended up scraping through and then doing quite well towards the end. Um, I'd say again, the strategy there for me would be if you find like you're really struggling in a particular topic or a particular class, try to use that as a um, opportunity to teach yourself to be a bit more assertive in getting your needs met and getting supported. Like book a time to see your tutor. Ask the questions in the tutorial. Like risk looking like you don't know what you're talking about. Risk looking lost and overwhelmed. Um, yeah, and I think like every time that I did that, every time that I booked a meeting with a tutor or put my hand up in class to ask a question or whatever, I felt like shit in the seconds beforehand. My face was red during it, but good came from it. And so I just really encourage people to do that sort of thing.
Some very good advice there, thank you. And I'll agree on the stats. My cohort is currently not having a great time with that class, but we're getting through.
Painful. Yeah. It
Our
is,
next,
I was saying for that flippantly before, but like essentially it is a new language, really, like that you're trying to learn, and so you know, to, I think like I feel like there's a lot. We all kind of know that a lot of people are struggling with it, but still we want to kind of hide the fact that we're struggling with it. And I think the more that people can just kind of like help each other and ask for what they need, the better. And the other thing is like when you ask someone for help with stats, usually the person who helps you ends up understanding and learning a lot more than you do. So it's, it's in the end not that selfish to ask for help, usually benefiting the other person too.
Definitely, you've got to fight that imposter syndrome somehow, and
Hmm.
sometimes teaching is the best way to learn yourself on some things.
Heck yeah.
Our next question is being introverted or shy a con when it comes to being a good clinician? Were you nervous at all before meeting your first client?
So again, I was probably feeling a lot of things that you might call nervousness, but I convinced myself I was just quite excited. I was really excited. I think it was a long time coming for me to just actually get into the room with somebody. So I was really happy to be there. But it was really nerve wracking, of course. Doing anything for the first time is really nerve wracking. Um, Look, I think being introverted or shy definitely has some cons in terms of being a good clinician, but so does being really outgoing and really extroverted. So, like whatever virtues you have in your personality, um, you can use them in ways that really help you, but there are also going to be some cons that are going to trip you up. So, like for example, if I'm feeling really extroverted and excited and feeling really outgoing, the chances that I'm going to talk over somebody in a session or miss a little window where if I had have been quiet, they would have opened up a whole new thing that would have been good for them. Like I could be making mistakes like this all the time because I'm too extroverted. Being introverted or shy, you know, you might find that people are really a bit less comfortable with you when they first meet you because it's a bit more they're required to do a little bit more interpersonally to get to know you and for you to get to know them. And so that might be a bit of a tricky thing that you need to work with is like developing that initial rapport, because it's much harder for you to kind of overcome those barriers. But a benefit might be that you're quiet in a point where it was really good that you were quiet then, and it let someone just have a moment of reflection that they otherwise wouldn't have had and feel like you don't need anything from them in that moment. So I think that every personality trait that you've got can be a tool, and it can also be it has like a shadow side to it that is worth keeping an eye on. And so I wouldn't, yes, it does have cons. It's also got pros, and your job as a clinician is to kind of like keep an eye on when that balance is getting a bit too out of whack and kind of fixing it up a little bit, you know?
Very nice answer. Moving on to our next question. What are your thoughts on the medical treatments for alcohol use disorder? Do they have any benefits over psychotherapy?
So, alcohol use disorder is a really tricky one because um, depending on like alcohol is one of those drugs where depending on how much someone is using, it can be physically really dangerous to stop. And like I've had moments where I've overheard or seen someone advise someone to quit drinking and had to step in and like kind of ha- um, bring a new plan in because it seemed pretty unsafe for me for them to be saying for this person to stop drinking because it can be really like it can in extreme forms stopping alcohol suddenly can be fatal, I'm pretty sure. So the medical treatments are going to really depend on how much someone is drinking and what their pattern of drinking looks like. um, so if it's a alcohol use disorder, I would probably want a psychiatry assessment. I would want like a doctor involved in that process, and I would not want to be the only professional involved. But I would be able and willing to help alongside the medical treatment for stopping alcohol, um, or again refer on to like a addiction specialist if it's that bad. Um, My sense is that if someone is really addicted to alcohol, they're probably going to need psychotherapy as well as medical treatments because, like I said earlier, the tricky thing is going to be the lifestyle adjustment that needs to happen to support that person not drinking anymore. And I think from my perspective, the trickiest thing there is usually the social domain. And a lot of people, once they medically overcome the withdrawals and stuff from stopping drinking, the tricky thing is the fact that they've got no friends anymore, or they can't actually talk to anybody because all of their social encounters happened with alcohol or in a pub or something. So psychotherapy is really necessary in those moments, I think, to help someone kind of like build a new life. But yeah, medically, you need the professionals involved, I think, to combat alcohol disorder because it's just so physically dangerous.
All right, thanks for that insight on that. Our next question is, when do you think the DSM-6 will be released?
No idea. It's a really interesting question. Like I was thinking the other day about how fucking stressful it would be on one of the committees for the DSM. I just can't imagine the processes that they go through, like organizing steering committee meetings for all of the different psychiatrists and lawyers and um, uh, policymakers and all the different, like even just figuring out who the stakeholders are who need to be at those meetings. Far out. Like we have steering committee meetings all year just to organize like one survey that we're going to release to the patients at the hospital. I can't imagine what goes into like organizing a DSM-6. So yeah, who knows? That's not my area of expertise, but it'll be really interesting to see the changes that are made. I think one of the one of the interesting things is going to be what happens when there's a few terms like like the term psychopathy that gets brought up quite a lot, where for a long time we've been able to say, oh, it's not actually in the DSM. It's not a term you're going to find in the DSM. It's not a diagnosis. If it actually becomes one, it's going to be a game changer in how we talk about some of this stuff. But no idea when they're going to get around to the DSM-6. Interestingly, the other thing is that one of the interesting things I found is that working in a hospital, we actually use the ICD, and so we have to give a diagnostic code for every encounter we have with any patient, which really rubs me up the wrong way because I'm not used to working closely with diagnoses. I don't often offer diagnoses. Most of my time is probably talking with people about how they don't have a diagnosis of an acute psychological disorder. But yeah, it's really interesting because most people in pop psych realms are used to the the DSM categories and stuff. But then in the hospital setting, we're encouraged to look at the ICD codes, and they're quite different. And they're a lot more. There's a lot more of them, and they're a lot more nitty gritty and a lot more context heavy. And so yeah, it's interesting that there are these two kind of books that go around. Almost like competing for this same space. And DSM seems to win in an academic setting, but then ICD tends to win in this clinical hospital setting. And I don't know how that's going to sort of, I don't know how those are ever going to be synthesized or integrated, really.
It does sound like a very difficult situation for them. Our next question is, do psychologists at your hospital wear white coats like physicians do?
No, no, no. The doctors don't wear white coats most of the time. They wear tucked in smart shirts with lanyards. I very rarely see anybody wearing a white coat. And then the psychiatrists are very well dressed. They dress like either the same as the other doctors or even a bit fancier. You know, that's where you get some of I do see people in their three-piece suits every now and then. And then I wear very smart casual clothes because I've had enough experiences with patients who have um, specifically said that they walked out of a psychiatry appointment when they saw that person wearing a suit, and they literally did a 180 at the door, walked out, because they were so convinced that this person in a three-piece suit would have no shared reference points and would not be able to understand them at all. And then at the same time, you have people who want to call me doctor, no matter how many times I ask them to call me by my first name. They just call me doctor, and they really want to know that I have a lot of authority. That makes them feel a lot better. So I try to strike a nice balance in the way I present myself between like a fairly accessible, a little bit slightly eccentric, unusual person, while also being, smart enough that I don't look like I can't carry a piece of expertise with me. I tuck in my shirt, but the shirts are a bit odd.
Thanks for sharing. Our next question is, what do you think about imposter syndrome? Do you think people who suffer from imposter syndromes can slowly turn into covert narcissists? That's an interesting question.
It is an interesting question. Can people who suffer from imposter syndrome slowly turn into covert narcissists? Now, that's a very, very interesting question. It's really insightful, right? Because um, essentially, whoever's asked that question, they're noticing the fact that someone who is um, calling themselves an imposter is really focused on themselves, and they're really focused on what other people think of them. And you might even, if you look at all of mental illness as as a spectrum, we might say, hey, if we took that to its extreme, they might not be able to. They might not be able to stop being so focused on what other people think of them and how they stand up and how they compare to other people, and you know. So I can see the link there, um, and it's really quite a nice antidote to anxiety and paranoia and imposter syndrome and that sort of thing, to just get very curious about other people. And often, um, when I find myself feeling really focused on my own anxiety and my own standing in relation to other people in a meeting or in a room or in a therapy session or whatever, um, I will try to ask myself, how are they feeling right now? Do they feel like they belong here or do they not? And so, like, I think it's a really great question because it points to an antidote that I think works quite well in that situation, which is to turn your attention away from yourself and onto other people. Um, and I think the other thing I would add to that is that it's really nice to put words to those experiences and make them a little bit more shared. So I remember recently I was called into a wardroom because someone was just like screaming and screaming in there, and they had a whole team of nurses panicking out the front of the room, like not really knowing what to do. This person had like really age regressed, so they were like really just overwhelmed and distressed and trying to hit their head against the side of their bed, and they were just like, so you go into a room like that and feel helpless, like what can you do? what can you do? I could walk up to this person and try to tell them about relaxation strategies. They're not going to land. I can maybe break some of the social rules I might keep in other situations and hold their hand or like touch their shoulder and just say soothing things or make soothing noises and try to be stable. But I feel like a complete imposter because they've called me into this room to be like some expert clinical psychologist. But like, what can I do? Like, this person's just screaming, having an episode. They can't hear anything I'm saying, really. But the benefit I think that I had in that situation was like just sort of being a bit of a soothing presence for everybody there. But then afterwards, saying to some of the people, "Hey, I felt so helpless there. Oh, I felt so just it felt like there's nothing I could do. What an awful feeling." And then the nurses like, "Yeah, I know, it's awful. Like feeling that helpless or like I want to do something. There's nothing I can do." So I think the problem with these things like the imposter syndrome is it makes people feel scared to share their feelings about inadequacy. But when you are able to share them in a functional way, like other people can relate to it, and then everyone feels a little bit better. Like everyone feels like, oh yeah, it's okay to feel a bit helpless. It's okay to feel like there's nothing any of us could do there and stuff. But if everyone in that room feels like an imposter so much that no one can say that, then everyone just leaves feeling worried that they were the weak link, and everyone leaves feeling guilty, like, oh, I didn't do what I should have done to help that person, or, So I think I really like that question because I think there is something a little bit narcissistic about imposter syndrome in that we're focused on ourselves. And perhaps the antidote to that is to focus a little bit more on other people or share what's going on for you with those other people and see what comes out of it.
Thanks for your insight on that pretty tough question. And we'll move on to some lighter questions after that one. Our next one is, what brought you to Psychology Den and what makes you stay?
Um, so I, well, firstly, was really into debate culture on YouTube, those awful dramas. And then it was like, what is this Discord program that they're all using? And I searched for it and found it. And then I went through this phase of like searching around for different servers and stuff and testing the waters and then realizing, you know, uh, none of these are very good. And had a few, experiences in various servers and eventually realized, oh shit, there's all these people doing like psychology and mental health stuff in Discord. That's like interesting. Found a few of those servers and was not very impressed with things that were happening there. I tried to become, a bit more active in a server offering support to people, but really didn't like the way that was being done. And yeah, eventually I found PsychDen and was like, oh, this is the first time I've seen like a community here on Discord that really A, fits with my interests, and B, like the culture is really cool. People here are really nice and friendly and they want to have fun and be silly with each other, but also like know when it's something serious is happening and be sensitive to sensitive topics and that sort of thing. So yeah, I eventually found this place and just really like it. And slowly my style my style when I go somewhere new or go to a new culture or a new thing is to sort of hang in the background for a little while, get a sense of what's already happening, and then slowly look at like places where I feel a bit of a drive to like get involved. And like, so for me that was like a few conversations I saw happening and I started to get involved in those. And you know eventually we all start like influencing the culture and not just looking at it. We all like you start like actually shaping it. And yeah, this place has been, I think, really good for my development because it's like a place where um, there's way less formal pressure to like um, present yourself as though you're at a conference and everything's really serious and stuff. But it's academic leaning enough that people can kind of explore, I think, really interesting topics and sort of gather their thoughts and experiment with their thoughts in certain areas. So it's really cool. Yeah,
Yeah.
and as Easy said, like to get some confidence in like just talking about psychology and being able to like just talk about this stuff without having so much fear and anxiety attached to it about like saying something that's slightly incorrect or slightly wrong. And so I think there's like these spaces where everyone is being really reckless with the way that they deal with mental health and psychology, and then there are spaces where everyone is really uptight and really scared and that kind of thing. And so I think Psychem strikes a nice balance between like treating sensitive things with enough reverence that we're not doing damage, but being lighthearted enough that we can all just build up our confidence a bit and just not approach these topics with so much fear and trepidation and nervousness.
Thanks for sharing your thoughts, and that's very high praise coming from you. I'm glad that you've been able to find a community here and stick around as long as you have.
Me too.
Our next question is, what does a typical day of work look like for you today? What does a week look like?
Yeah, so keeps changing. It keeps changing. In the clinic that I work in inside of this hospital, we've got like a handful of psychologists, and um, the foundation of our work is that we're each carrying a certain caseload of patients who we are responsible for their mental health. Um, and so most of that's like the core of what I do is that I will be allocated a patient at a certain time. I go and do an assessment with them, and then it's up to me to kind of make a plan with them about how I'm going to help. Um, Around that, there are the issues of triage where we need to all take it in turns in the clinic to be calling up the referrals and checking in how they're doing, how bad things are, and booking them in for their new assessment with somebody. So that's like a whole task in itself, triage, which can come up with all sorts of problems where you're trying to sort of make clinical decisions about how long somebody can wait on the waiting list to have their first appointment and all of that sort of stuff. There are all sorts of multidisciplinary meetings at the hospital that take place. So, like the palliative care group, the pain group, the surgery prehabilitation group, the rehabilitation group post surgery, the allied health meetings, the research meetings, all of this stuff. And so all of us in the clinic kind of like just take it, we allocate ourselves to have these various projects that we look after in the hospital. And new ones come up and old ones sort of finish up. And yeah. So my week is sort of really the bulk of it is having sessions with patients in the hospital and writing up reports about those sessions. And then the other stuff is like meetings, having consultations with various doctors about how patients are doing, or coming up with plans with nursing staff, and you know, or organizing uh, how we're going to support somebody 6 months down the track, and coming up with a bit of a plan and writing up that plan so that everybody involved in their care knows about it. All these sorts of like clinical things. Um, yeah, and then just lots of meetings about lots of different projects that are going on all the time.
That sounds very busy, and we have come up on 2 hours, so I just want to check in real quick. Are you good to keep going, or would you like to wrap it up soon?
I mean, I'm okay, but I don't want to be an imposition. I'll go as long as you want to, and I'll tell you if I need to wrap it up.
No, you're good. I'm good to
Mm,
keep on going. It looks like we have about 13 more questions on the spreadsheet. So if we can get through that, I think that'll be
cool,
nice.
cool.
All right, we'll keep on going then. Our next question is, do you have any conference recommendations?
Um, Not really. Like, I think I've been pretty slack with conferences because of COVID, really, and and so a lot of the conferences have just been, you know, they've stopped being these like really big fun events that people travel to and go to, and they've become just like one more Zoom meeting that you do in the day, you know. Because like the last conference that I did was on psychedelic medications, and it was just like, you know, an online thing. We just had session, you know, webinars and Zoom discussions and that sort of thing. So I don't know. It's all a bit of a drag these days now that it's just like more time on the computer and more time like staring at these little boxes. Um, I think conferences are really good just to like pick an area that you're interested in right now, and just like ride that wave of interest. The best thing that I get out of conferences is not like one particular piece of information, although I do get taught a lot of really interesting things. I think it's just like keeping your passion up and keeping your interest up, and you know, helping you to realize that there are other people doing all of this work, and finding out things. And so yeah, because when you're working with patients, you're kind of like teaching yourself the things you need to keep working with them responsibly anyway. And then conferences are like kind of like opening up, well, for me anyway, they're just like opening up new options of possibilities of working in new ways, and new perspectives and stuff. So I think they're important for me just to keep my interest up in the field. But I don't have any particular ones that I would be able to recommend.
No problem. Our next question is, what is conducting neuropsychological assessments like?
I don't know. I don't do neuropsychological assessments. I do just quick and dirty mental state examinations, which is just like a little assessment about how someone is feeling and thinking um, right here and now, and how intact their cognitive processes seem to be, and how orientated they are to their current situation and their environment. If situations require more than that, I'll refer on to an actual neuropsychologist or a psychiatrist to do an assessment. And comes up, it comes up a fair bit in the hospital because there's so many issues around capacity for consent. So where someone does, or where people have a suspicion that, well, hey, we don't actually know whether this person's thinking clearly enough to provide informed consent, or reject this medical treatment, and so they need to get someone to assess that. So yeah, it'll either be a neuropsychologist, or it'll be a psychiatrist, or it'll be a medical doctor to do those assessments.
All right, moving to the next question, then in that case, how common are personality disorders and what makes them so hard to treat?
I mean, I think personality disorders are fairly rare. I can't remember off the top of my head what the ballpark figure is, but I mean, I think we're dealing with like, you know, 1% of the population or around that. Um, what makes them so difficult to treat a lot of the time is that for me, is that they're, well, A, they're not the focus of the treatment. So a lot of the time when you're dealing with someone who has a personality disorder, or like, you know, tendencies or traits like that, um, their personality is causing a lot of problems for them in life, but they don't see it that way.
Mm.
It's the other people around them that are causing problems. The it's the systems that has been set up this way. It's the corrupt hospitals. It's the pharmaceutical industry. It's the it's the doctors, it's you, the psychologist, it's it's all these other things that are the problem, and um, so it's really hard, I think, to help someone in that situation because uh, we're trying to like shift the focus onto the parts of themselves that they might be able to change, or the things that they might be able to do a bit differently, or experiment with to fix the problems in their life, but without doing it in such an obvious way that we're putting their personality on the table and calling it a problem, such that they just walk out of the room. So I think that's why they're really hard to treat. And I think I spoke a bit about this earlier. Like, I think inevitably when you're working with someone who has like a difficult personality, you can expect that the therapeutic relationship is going to have a lot of ruptures that need repairing, and a lot of the time the benefits that they get from psychotherapy come from those ruptures and repairs. They come from the fact that this relationship has hit a problem, either a real one or a perceived one, and then you are practicing together how those interpersonal problems can be explored and resolved in a nice way, in a way that doesn't make everybody's life really much worse. And that is really difficult. It's really difficult to do because it brings up all your own personal imposter syndromes, all your own sense of inadequacy, all your own often these people might make you you really don't like them a lot of the time, or they'll make you feel really helpless. So the problems they'll talk about in terms of like the world is so fucked, everything's fucked, the hospital's corrupt, everything's awful. They'll point to kind of like real stuff. They'll point to like real problems in society, and you can't just dismiss them so easily, but you also can't just let this person off the hook entirely. So yeah, that's the tension. That's the troubling dynamic with someone whose personality is really difficult. It's this tension between like what is the actual problem that you're both looking at. A lot of the time I'll be doing work with these sorts of people quite indirectly, so like we'll be telling stories, we'll be like chatting about stuff, but in the stories that we're telling, I'll be trying to illustrate how someone was able to overcome a problem in the hospital, what they needed to do to sort of overcome it, and so I'm like trying to illustrate solutions, or but I'm not doing it in a way where I'm like sort of saying to them, look, all these problems are clearly because you're so hard to get along with, or you're doing all these things. So it's like there are these indirect ways of working that are, I think they're just really subtle and they're really hard to learn. I'm still learning them, and they require a fair bit of supervision, and they require a lot of really reflective practice about what you were doing in the session. And a lot of the time, the reflective practice with personality disorders needs to be self-compassionate, not like reflective practice where you're beating the shit out of yourself about like how bad you were with that person, because you'll leave sessions with really difficult people feeling like, oh, I was awful, I was a mess, or I didn't do this, or I didn't do that. So being able to like focus on what you did offer them and what you did do that might have planted a seed, or is equally as important to reflective practice, and especially when you're working with someone with those flavors of personality disorder that really trigger like sense of inadequacy, or a sense of like helplessness.
Thanks for sharing your perspective on this. Our next question is again something we kind of covered earlier, but what was your favorite class in your undergraduate career?
Um, I really liked history and philosophy of psych, but it wasn't one I took. It wasn't available when I was in undergrad, but I taught it in postgrad. And I really liked that one because it was like a lot of the issues that people bring up here, they're just intuitively quite fascinating. Like, what is mental illness? What is psychology? What is allowed within the scope of psychology? What's not allowed within the scope of psychology? All of that kind of stuff. Um, I really liked that class, and um, so I took the textbook that inspired a lot of a lot of that unit, and just doing a reading group here based on that because I just think they're interesting topics.
All right. Our next question is, how do you deal with witnesses?
Ruthlessly, absolutely ruthlessly, and shoot first, ask questions later. Sorry, that was a bit of a meme question, but I think those in the know are in the know. I don't condone any violence.
I figured it
How,
was, but I
how
figured
is
it out.
that not you, Aiden? Oh gosh.
All right. Our next question is, how has being a clinical psychologist changed the way you interact with people in your day-to-day life?
Well, a lot, and it's tricky, because like I said before, that part of my role is breaking down taboos for people, or being someone who's not frightened by their taboos of certain topics, but um, you know those topics are taboo for a reason, and so it's tricky to relate to people sometimes, because even a question as straightforward as, oh, how was your week, or how was work, or how's work going for you, is like um fairly quickly we hit a full stop where I can either stop talking about my work with somebody, or we're going to be talking about death and illness and that kind of thing, or mental health problems and stuff. So it does feel sometimes like there's a bit of a chunk of my life that is sort of cut off from the niceties of just social pleasantries and that sort of thing. And that's a bit of a challenge. But and I think the other thing is, like, I am a little bit less tolerant of like boring conversations. I think I can't tell whether it might be a chicken or the egg thing. I can't tell whether I was attracted to psychology because I was already not wanting to have you know um, kind of pointless conversation, or whether it's been kind of like facilitated in me because I've been doing this work, but maybe it's both. But I find like my personality's probably become even more extreme since becoming a psychologist. I either deem it to be a conversation where I want to say something like that I'm really passionate about, and then I'll get quite passionate, or I think it's a bit of a meme conversation, and I'll be very silly and very like playful and that sort of thing. Um, yeah, so I guess like I'm just becoming more and more eccentric every day.
All right. Our next question is, what are your thoughts on safe injection sites?
um, I looked at it a while ago. I don't know what the current state of the evidence is today, but I remember a few years ago when I was looking at that stuff, the evidence seemed to stack up pretty strongly that they were a good thing. Um, Look, I think our society. Oh, sorry, safe injection sites. I'm assuming mean. I just saw in the chat, meaning like places people can go to use intravenous recreational drugs like heroin and that kind of thing in a safe way. Um, yeah, like I think that what I've read is that um, they've had a positive impact on people accessing. They've had positive effect on people accessing support for their addictions, and getting medical interventions and stuff. And the more that stigma can be reduced, the better. And places where people can be educated on safe use of drugs and that sort of thing. I think all of that, and a place where people can check in and make sure they're okay, and whether there's services that they might need. I think it's generally a good thing. I think our society's like really dropped the ball with how we approach drugs in general. The word drugs, the concept of drugs, I think is quite problematic in that it includes, coffee, alcohol, pharmaceuticals, recreational drug, like all these different things, and in the way that we sort of have all these different bodies of people trying to like weigh in on whether a certain drug should have a certain reputation or a certain set of institutions in society. Like, is it a criminal thing? Is it a medical thing? Is it a spiritual thing? Really tricky, and I think we've kind of really need to get a lot better at talking about that sort of stuff. And one obvious improvement seems to be to treat these things like to treat drug problems as medical ones and not criminal ones.
Very insightful answer, thank you. Our next question is, are there some psychological disorders without any biological basis? Should psychology make more of an effort to research biological underpinnings of disorders?
It's a really, really good question. I flip and flop on this one a lot. I mean, look, I love information and stuff, so I think psychology is making a lot of effort to research the biological underpinnings of disorders, and I think that's fine, and it should continue to do that, because the more information we have, the better. But I do think that we have, I do think that we go a little bit far sometimes with what we think we can say about um, about disorders and about the biology underlying disorders. Like, so everything has a biological basis. Absolutely everything that humans do every second of their life has a biological basis. So the question for me that's really interesting is like, when we are finding out about those biological structures underneath experience, what are we going to then do with it? What's the implication of finding the biological thing? So philosophically, the problems that I see in overemphasizing neurology and biology is, firstly, that it can be really reductive in like taking a problem and atomizing it and saying that like this problem that's happening is that, it's happening because there's something broken in this individual, this one person, as opposed to the way that their whole family is functioning and talking and interacting with each other, the way that their workplace culture is operating, the way that society is sort of spreading certain values or prescribing certain behaviors. So there's all these different like lenses and scopes that we can use to look at a certain problem. And the only problem with like getting too far down the track of biology is that it just locates the problem within one individual, as opposed to groups of people or cultures of people. The other thing is, I think it can, the danger of like going a bit too heavy on biology is that we can get a bit fatalistic about certain things, and we can like make this error where we think if something has a biological basis, that means it's natural, and this is the way things are supposed to be. And if something, if we're able to change that thing, that we're sort of going against biology, is sort of almost seen as like, like fighting what's meant to be or fighting what's inevitable. But like I said, everything we do is biological, including our attempts to transcend our own biological drives. And so I don't like biology being like this kind of fatalistic trap that people fall into. And so I think that's worth just keeping an eye on as well. Um, I think that what excites me about biological underpinnings of disorders is obviously the engineering question. If we know what biological stuff is going on under disorders, will we be able to biologically intervene either with surgery or with tablets and medications and stuff that can like really enhance people's lives? And that's cool. I think that's fine. Yeah, I just think like there's pros and cons to whatever lens you choose to look at these problems with.
Thanks for lending your thoughts on that specific question. Our next one is going to be, who were some of your favorite authors or professors, and what were they like?
I've had awesome supervisors all the way through my training. I've really liked my supervisors, and so I would like um, credit them more than anybody else in like where I'm at now and how I'm able to do the work that I do. Um, in terms of like authors, my favorite non-fiction author is this crackpot called Robert Anton Wilson, who writes like really eccentric and bizarre counterculture fiction and non-fiction about psychology and about uncertainty principles and all these different things, about conspiracy theories. It's just a really fun writer. I really like him because he's so entertaining and fun. His name's Robert Anton Wilson. Um, and then in terms of like academic stuff, I really like I really like uh, I I probably like pieces of work more than particular authors or professors. So like there's an article that I really like called The Psychology of Worldviews. And I was a bit obsessed with the author of that article for a little while, but I think it was really just that article that I liked more than anything else. There's a book that I really like called Attachment in Psychotherapy. So I like the author of that book, but it's really the book that I like more, more than the author. Um, there's a group of people at the moment doing some really interesting work that I like, named Ross Menzies and I think Rachel Menzies. I think it's a dad and daughter combo, and they're doing a lot of cool work on death anxiety and how death anxiety is like a transdiagnostic um, experience that could feature underneath most mental illnesses, that we could treat a lot of mental illnesses by treating death anxiety. So they're doing some really cool work. Um, yeah, I don't know if I could probably keep going. I get kind of really into a particular book or a particular piece of work as opposed to like a person, if that makes sense.
Sure thing. Moving on to our next question. How do you feel about the quality of your education?
Depends who I'm talking to. some of the
Good
people
point.
in some of the people in Psycden make me feel like I went to a little shack under a bridge to learn about psychology. Um, and I get the feeling that the quality of education that I had was really inferior, and I get a bit jealous. And then other times I talk with people, I think, no, I've been really, really lucky. I've had great supervisors. I've had, like a really good collection of classes that have like got the ball rolling and stuff. One of the hardest things I found is like if you I think psychology education is an absolute mess. But if you stop and try to actually think, how would I redesign this? How would I redesign like someone coming to me from scratch and being like, teach me psychology? how do you even start, like what that word even includes, what it doesn't include, and to go from there, you know, teaching all the basics of all the different like major subdisciplines and then honing in on each of them, and then like teaching the practical skills about research and the practical skills about being a clinician, and it's like an impossible task. So I don't know. I feel like, all things considered, I'm very lucky to have had the education that I had, and then it's kind of on me to supplement it as best I can now.
Great. Our next question is, how does religion factor into your work at all? Can clients work with their religious beliefs with you, or are they more often an impediment?
Um, oh, nothing's impediment. No, that's not true. So religion does factor into my work a fair bit, um, because I would say that a lot of people I meet are in the throes of a spiritual crisis. Um, and you know, when you look at the literature on this, it's really helpful to sort of get a sense of what spiritual crises are, or crises where people's core beliefs about reality have been challenged. Um, and it's really helpful for those people to have a space to discuss what's happening, and what their doubts are, and what's going on for them, with somebody who is able to talk sort of somewhat knowledgeably about religion, and have an open mind about religion, but isn't trying to, like, at the end of the day, make them believe or not believe anything. It's really helpful. So yeah, it features a lot, and I I don't like it to be a taboo area, but I also understand that it's very protected and guarded for some people, and it needs to stay that way. And so I will, I will honor their wish to keep it a bit protected if that's what they want. So yeah, I think that it's a really interesting area. Now, what gets really ethically tricky from my perspective is that we're going to start having a bunch of data about what sort of belief systems tend to have what certain effects on people's well-being, on their social life, on their life goals, all this kind of stuff. And it's going to be really interesting to see, like, the ethical dilemmas that creates, because you might say that there's a bit of an ethical tension between me as a psychologist not having the right to convert somebody's religious beliefs. But you also might say it's not very ethical for me to have scientific data about certain beliefs leading to certain outcomes, and being asked by my client about their beliefs and not sharing with them the clinical information I have about the psychological benefits about certain beliefs or not. I find that a really interesting area. Like, um, psychology itself can't talk about whether religious facts are true or not, because that's not what the science of psychology can do. It's not within the scope of psychology. What psychology can do is talk about what people do believe, and then what happens as a consequence of those beliefs. Um, Sometimes people tell me about their religion, and it's extremely helpful for them. It's like the most comforting thing they could ever have, and I just listen to them and think that's great. And I will, like, reflect it back to them, and so say, oh, it sounds like this is your, when you think about God, or when you pray, or when you meet with your congregation, you seem to get this and this and this and this from it. And they're like, yeah, I do. It's really good. And so they like get this greater sense of, oh, this is what I'm getting, and I'll keep that up. That's good for me. Other people might be in absolute turmoil. You know, they might be really worried that there's no afterlife and feel like they can't, and it's keeping them up at night, but they can't say it to any of their family because their family, as soon as they do, their family shut them down. Say, don't even think that way. Don't even think that way. It's really bad. So it's really complicated, religious beliefs. But yeah, nothing's off the table for me. I'll work with pretty much anything, but how I work with it will just really depend on the role that it plays in somebody's life and whether it seems to be having a positive or a negative effect, and what they're willing to change and what they are open to changing, what they might want to change or what they definitely don't want to change, that sort of stuff.
Very interesting and related. How does ideology fit into that? Do any political ideas get a framework for existing, or are they more often, again, an obstacle?
Um, Ideology can be a big obstacle, but not really for me. Not really for me in coming across specific ideologies. More about ideology in general can be a bit of an avoidance for psychotherapy. So, like, Freud talked about intellectualizing as a defense mechanism for the ego. And I think that, that's a really helpful thing to be aware of that people do, because it's so clear. You can see people doing it all the time where like things get a little bit personal, they get a little bit uncomfortable, and then what they'll do is they'll shift the focus of the conversation away from them in particular, and they'll want to talk about people in general, but that's just society in general, or that's people in general, or that's this, so they take it to this really broad, really large abstract place, because that's so safe. It's so safe. It's a way that you can basically like have a full conversation with someone and talk about nothing of consequence. And so I'd say ideology is often an obstacle, but not in the sense of like an ideological clash. More so, just like people wanting to just chew the fat with me and stay philosophical or stay ideological and not actually talk about the nitty gritty of their own life. Having said that, some people get really distressed by certain political things going on, like COVID, responses to COVID, climate change, the corruption of the pharmaceutical industry, all this stuff. And if that's a place where someone's legitimately trying to work with their distress and understand their distress and where it comes from, and work out how they can integrate that into their life in a constructive way and that sort of thing, it has its place in the work. So I'm not saying that like any of those political topics are just like, always an avoidance, but they are often an avoidance, I think. I think like by the way, this is where I think Jordan Peterson gets into heaps of problems when he tries to talk about what I think happens a lot of the time is he's trying to talk at the level of psychology and psychotherapy, which is a very individualistic practice. It's like you and one other person having an intimate relationship, figuring out how they can reach their potential in their life. And that is such a fundamentally different lens than looking at like society and how society needs to change to serve everybody better. And I think like Jordan Peterson's like awful mistake is like when he sort of sees the changing the focus on society as like only a cop out. It's like only a distraction from the individual responsibility that we have to improve our own lives. But both things are happening at the same time. And psychotherapy is a place where people can work on themselves, but there are heaps of contexts where people can also work on society, like politically and in volunteering and in activism and all that kind of stuff. And they can both happen at the same time. But it's about kind of like figuring out which one you're doing here today, now in this session. Does that make sense? So I imagine, like, for Jordan Peterson, if he's done like 40 years of therapy or whatever, for him, when people were talking about society at large, most of the time it was probably like this thing that they were doing in front of him that was like stopping them from improving their own individual life. But then you can't turn around and say that of everybody doing activism and doing collectivist stuff. It's just that because they're not in a therapy session right now. If they were, then you'd turn your attention to like more individual stuff. Sorry I ramble so much, everybody. I'm using this as a excuse to just ramble away.
No, you're completely fine. I don't think you're rambling at all. And even
My
someone in
puppy's
the
got the
chat.
toothpaste.
Oh no, do you need a moment?
Nah, it's alright. I got it.
All right, and people in the chat are supporting your rambles, so you're doing fine. Our next
That's
question,
easy. I am developing them.
go ahead.
It's all good.
All right, our next question is, what is the best lesson that you've taken out from your experience and career to this day that you think would benefit someone who wants to follow this same career path?
Um, best lesson. It's a very Zen lesson. a very philosophical lesson. Um, try not to get too focused on uh the end result. Try not to get too focused on like down the line what is this career going to look like, where like it's great to have a plan. It's great to have like a career path and a vision for where you want to end up. You should have that. You should make sure that you know what the next step is that you need to take to move in that direction. But I think whenever you're involved in like a field like this where there's always more training to do, there's always more expertise to gain, there's always more patients to see, there's always more problems that new problems that you don't know how to approach properly and that you need to go back and learn about and all this stuff. Um, you're never going to get to that finished point. Like you're just never going to get to the point where you feel like now I've made it. Now I'm like there. I'm finished training. I know it all. It's just never going to get to that point. We're all in flux. It's like a complete life's work. You will never finish. You'll die before you know everything about psychology that you want to know. You'll die before you're as good at doing psychotherapy as you want to be. um, it's all a long life's work. So go a bit easy on yourself and just remember to like take stock of the good stuff that you are doing today and tomorrow. It's really easy to miss. And again, the training and the uni experience really forces you to learn to just work your fucking ass off, and then as soon as that thing's finished, you just move on to the next thing, and you don't take any stock of like the good stuff that you've done, and we just like really get good at being very compassionate to everybody else and really awful to ourselves. So like I think if you're following in this career path, you got to keep one eye on the vision way up ahead, but keep one eye just on yourself right now and acknowledge everything that you're doing that's really good.
All right, thank you for that. Our next question is, how easy is it to do things outside of undergraduate studies, such as school life balance and work, friends, and relationships?
Um, Undergrad was a big party for me. Good time. I had a really awful time in the first year, and then I really pushed myself to make friends and get a bit more social, and really that was when my grades started improving too. So ironically, it was only when I started being more seeing uni as like a place to socialize and a place to have fun, not just study. That was when my studying improved as well. um, so yeah, I thought there was a lot of time in undergrad to do other things, and in fact, like you really just need to make time to do other things. And I think like the more you can use undergrad as like a place to practice balancing all the different demands that life places on you, the more you'll be in a good position to just carry that in after undergrad. So, for example, just having a weekly schedule where you know you're going to have enough hours to get the work done that you need to do, you've got some time to catch up with people, and I literally had to write out a Monday to Friday timetable and include things in it like go to the gym, go to the pub, like hang out with my partner. Like I had to just plan it all out. I don't do that as much anymore because I feel like it's much more integrated. But yeah, I think how easy it is to balance all that stuff is probably just going to depend on how good you are at balancing things. And if you're not good at balancing it, I feel like you really need to get good at it. And I'd say that's the number one skill that I would encourage people to train themselves up in.
Fantastic advice there. Our next question is, what drew you to the existential approach to psychology and therapy as opposed to other approaches?
Um, well, probably all started when I was 10 years old, and I watched The Sixth Sense when I shouldn't have, and then went through an existential crisis, and I was like just asking everybody for weeks and weeks and weeks, what's the point of this? What's the point of that? What's the point of any of it? So I was a real doom and gloomy 10-year-old. And anytime anyone would sort of like think they had things figured out, I would just think they were kind of full of shit and didn't really get the real thing underneath it all, which was a total unknowable mess. And I started reading about existential stuff fairly early on, and so I read Yalom before, and I read like the existential psychotherapy textbook before I started working with anybody because I just really wanted to know, can you get to answers in that space? And I read some of the existential philosophers and stuff. Um, So I don't think it was ever as opposed to other approaches. I don't think like I ever thought to myself, I want to be an existential psychotherapist. Um, I think what I've been really interested in is that problem of meaninglessness and that problem of purposelessness and groundlessness and just feeling like nobody really knows why we're here or what we're meant to be doing and stuff like that. And I just was really interested to see whether anyone had a satisfying answer to that. Um, and for a while, I was looking for an answer, and I sort of thought more and more and more, no, nobody does. And then I sort of came to that position that a lot of us come to, where I sort of thought, well, it's up to everyone to get to their own answer. Everybody has to like find their own meaning of life or their own purpose of life. And then that kind of naturally got me interested in this question of, well, yeah, but can we help people do that? Like, is there a way of like fast tracking that or doing that quickly? And that was part of my interest in psychedelics. It was a big part of my interest in psychotherapy. But again, it wasn't really like, I want to do this as opposed to what everybody else is doing. It was more just like, is this an area that you can actually help people in? Um, and I I really just liked the Lom's work, and I liked a lot of what the existential people were saying, and like Sartre and like Robert Anton Wilson in his fiction and all of that stuff. And I just sort of am really passionate about having those sorts of conversations. And so I just kept trying to put myself more and more in places where those kinds of conversations were happening. Yeah. So I think that most of the time people will just have a crisis of their life at some point, where they feel like their core beliefs get really challenged. And I think it's really, I was really lucky when I was growing up that I had a good psychologist and other responsible people around me who were like really patient with me while I was going through that, and really open minded, and didn't shut me down and didn't call me like immature or whatever. Didn't like, even though they've probably had all these like existential thoughts before, they just let me kind of like go through it. And just really like, I just thought that was a really valuable thing, and I wanted to sort of do that for other people as well. Sorry, that's a lot of answers to one question, but there wasn't really one thing. It's sort of like a life of just being interested in that sort of stuff, and like pushing myself closer and closer to places where that was happening.
No, you're fine. Never apologize for giving too many answers. I'm sure the person who asked this is very appreciative of it. I think
What I really liked about the placement I did in the hospital was that I went through the CBT training, and then I did the CBT work with some people, and it was really helpful and it was really great. And then I met a bunch of people in the hospital whose issues were so full on that just trying to approach them from like a structured CBT, or I'm a psychologist, here's some strategies, like it just didn't work. It just broke down. They were in an absolute crisis, like I was at 10 years old. Like, what's the point of any of this, you know? And being able to like experience that really inspired me to stay at the hospital, because it was sort of like that there's part of the work that I want to be able to do, which is like being able to like stay on top of good strategies and just deliver them to people. And there's another part of the work that I want to be in, which is like, what do you do as a human when you're with someone and those strategies break down, and you're just there with them, and you have to try to like come up together with something therapeutic and spontaneous. And yeah, I that kind of stuff really just makes me feel alive, and so I want to be where that's happening.
very interesting answer. Thank you. Our last question on the spreadsheet is a little bit of a meme question, but I'll ask it anyways because I know someone's dying for the answer. Did Disco Elysium please your psychologist brain?
So much, so much. It's definitely the best game ever made, so far, and I am really scared about finishing it, because it's one of those games that like I've been slowly playing it, chipping away piece by piece, and you know, it's just sort of like the vibe of it, the music and all the psychologizing and mentalizing of the dialogue in that game just stays with me throughout the day, and I love it. And so I'm sort of just a bit worried about finishing it and closing that chapter. So I'm slowly going through it. I think I've nearly finished it, but yeah, it's definitely the best game ever.
All right, so that does wrap up all of our questions on the spreadsheet, all 50 of them. Thank you, Drolly. I think we'll go ahead and try to wrap this up. If anyone has any remaining questions, please post them in the Presentation Den channel at this time, or you can go ahead and raise your hand and I'll unmute you really quickly. So we'll give that a moment or two for them to get their lingering questions in real quick.
While we wait, I was teaching a group of students about Erickson's model once, which is, you know, that model about psychosocial development, and you sort of have different phases of life where you have a different problem that rears its head at you, and the last phase is integrity versus despair. which is where people are kind of doing a bit of a life review and looking over their achievements and their failures and trying to like either treat themselves with dignity and integrity or just totally despair about their life. And um, we're talking about like using that to inspire questions in psychotherapy, and a lot of the students were really horrified about like asking somebody about like what they thought of their life at the end of their life, like was it a good life, was it a bad life, and people were mortified at the idea of asking someone that, and that's always really interesting to me because I would think it's awful that no one asked, right? Like you get to the end of your life and no one actually asks you that question. And so when I'm looking at over these questions that people have asked in the AMA and stuff, it's really interesting like what people choose to ask and what they don't. And I find like some questions are just like they're so helpful. Like that one about narcissism and imposter syndrome was really helpful. And if no one asked you that question, like you'd never be able to develop your thoughts in that area. And again, I'm just reminded of like one of the good things that we do as psychotherapists is just like we get really interested in people, and we get interested and curious and stuff about people enough that they have a chance to like develop their own thoughts. And you guys have like done that for me now. It's so sweet. It's so nice getting like all these questions and being like, oh, what do I think about that? Um, where am I at with that now? I get a little taste of what to give other people. It's really nice.
All right, so it has been a few minutes and I don't see anyone raising their hand or posting any questions in the chat, so I think we'll wrap up for tonight. Thank you so much, Drolly, for joining us, as well as all of our
Pleasure.
audience members.
Thanks for all the questions, and thanks so much, Enda. You make these AMAs super easy. It's really wonderful.
That's my goal. If you'd ever like to come back for another AMA or presentation, just let me know and we can get one set up.
All sounds good. And I might put a poll up. It'd be fun to like try to do a presentation, but it might be good just to see what people actually want to hear about together, because I think that'd be fun. And then we could have like a discussion about it afterwards and questions and stuff about it afterwards. But I might have to put some polls up and see what people actually want to talk about.
Definitely. BK, when
Mm.
he did his, had a fantastic time and we had a lot of very insightful questions afterwards. So I think a lot of people would be very willing to come out for something like that from you.
Yeah, that'd be cool. Awesome.
All right. Well, thank you for coming out again and have a great rest of your night, everyone.
Thanks, everyone. I'll see you in the other channels.